Well, good morning. Thank you, Dr. Hipskind, for joining us today. Dr. John Hipskind is the Ultrasound GME Director and a Fellowship Director at the Department of Emergency Medicine at Kauai Delta Medical Center. And we're going to talk about synchronicity. We're really excited to hear about this because you're going to be one of the first installations, not only in the country, but in the world, and really trying to solve workflow problems. So thanks for joining us today.
My pleasure, Dr. Mandavia.
So John, why don't we just start a little bit, maybe just tell me a little bit about yourself, and then we'll get into the hospital and the department, the environment.
Sure. So I graduated in '95 from Cook County Emergency Medicine Residency, and then have been here at Kauai Delta since then for my entire career. So we have the hospital itself has grown over the years from a single coverage non-residency site to now a multiple physician, multiple APC, and a residency site where we have 5 residencies at our hospital. So it's been great to see the growth in volume, and then we've made a number of changes over the years as well too, just to accommodate that. We're some rough numbers. We're a 450 bed hospital. It's a single standalone community hospital, and we have 42 ED beds to manage a volume. Pre-COVID, we were inching toward 100,000 in the mid-90s, and then post-COVID is kind of anyone's guess, but we took about a 50% hit. We're probably on path to be about 70,000 this year. So it just depends how quickly things bounce back.
So John, sounds like you're a pretty big shop. As far as ED volume, I think the listeners should know that this is on the higher end of volume. Sounds like you're a bit of a blend where you switch from the hospital, the institution switched from a community hospital now turning into a pretty large teaching hospital. And tell me about the size of the residency and the fellowships, and if you have a trauma center there, that sort of thing.
Sure. So about 10 years ago, we started to realize we were having difficulty recruiting physicians. So what's the best way of doing that? And that's starting a residency program. So after a few years of planning, preparation, seeing which departments would be best suited, there were a number of areas identified. So we started our first residency classes in EM and family medicine about 7 years ago. And we've grown the program. Each started at a smaller side, and then we've grown to now, for emergency medicine, 13 residents a year. And in total, we have about 125 residents on campus from the various residency programs. We're a level 3 trauma center. We're the only one. We're in the Central Valley of California, which is the other California most people never heard of, but we're between Bakersfield and Fresno. And so we have a fairly large catchment area. And I think our population, our city itself of Visalia is about 125,000, and our catchment is probably close to 500,000 folks. We just started, this is the first year of our ultrasound fellowship program. So we're really excited. Was one of our chiefs from last year, and he's helped bring us to the next level.
Wow, so it sounds like a fair amount of academic growth. And you're right, it's certainly an attraction, certainly to young physicians. And it sounds like your catchment area, so your volume is going to be pretty large. It's already reflected in your ED volume. And the lack of other sort of large centers around you means your acuity, I'm sure, is pretty high.
Yeah, that's true. We just, we serve as a state. We're not technically a county hospital, but we definitely are a safety net hospital. And the numbers reflect it, and we enjoy, we have a large population that has a lot of untreated or undertreated medical problems with poor access to care. So it's great as a residency program to have that degree of pathology and number of patients. And we try to really meet the community needs, and I think we're doing a decent job.
Fantastic. So let's switch a little bit now to ultrasound. So it sounds that obviously in a really busy ER, trauma center, and of course an academic center, you're doing a fair amount of ultrasound. Can you give us a little bit of idea of the sort of volume of how many scans you guys are doing a month or a year?
Yeah, so it's been slowly increasing. I think at first when we started the program, and then it was, of course, EM required ultrasound training, we had several older units, and we've really been able to ramp those up. So right now we have 4 of the Sonosite exports, and they've really done a tremendous job for us. We have a couple of the older units that are now relegated to kind of IV starting duties, and our volume has reflected that. I think while it's tough to compare apples to apples, because recalling that, I'm trying to project pre-COVID numbers to post-COVID numbers. Clearly, the volume has gone up, and I think our last quarter of the last quarter that we measured, we probably were about 1,200 ultrasounds, so 400 a month divided by, so somewhere around 15 to 20 a day, just in the emergency department. There are other departments that utilize it, but they don't have a middleware to track it. And so we're working on that as well too, as we've kind of solidified and captured the ED. Our next partnership, we're looking at the family medicine clinic, who I'm very jealous of. They picked up the PX, which we don't have, but they have one. And then of course we want to get them the middleware, hopefully synchronicity. And then we'll look at other departments, high utilizers like ICU, cardiology, OB.
Got it. So it sounds like a reasonable volume. And you did mention, which I think is worth reiterating, that every emergency medicine residency in the United States has an obligation not only to teach ultrasound, but to sort of do QA in ultrasound and sort of catalog all of their exams during the residency. And the residency could be 3 to 4 years long. So tell me about that, just on that component. How were you managing the ultrasound program part of this for the residency teaching prior to the synchronicity installation?
Sure. So we had obviously we had a competitor, since synchronicity just came out. Not to mention any 2-syllable or 2-letter acronyms, but it was a difficult system to use at best. I would compare it to a DOS, to a Windows-based program. So QAing was challenging for a number of reasons. Often it was difficult to identify the interesting cases. There was no really good way of marking those. And trying to go back retrospectively and match up the cases that a particular resident did with a particular attending was a challenge. So when you QA'd, you try to match up all those and get some meaningful feedback to help them with their techniques. The other thing that was difficult on the QA process was that you could not, there was no real-time feedback. So if I'm sitting down and I wanted to go through a few days of some accumulated QA work, I'd also have to have open my email program, and I'd have to take tips that I saw for improvement and put them and then email it to that person in a compliant fashion. So it presented a lot of challenges versus the system that we have now with synchronicity, which is when I QA the patient's chart, when I QA the not only is that program the QA changes since we've had it, visible to the needs of the folks doing it, but it also provides immediate feedback, because at the end you're allowed to send those comments directly to the hospital email of the resident that did the case, or even sending to the case. So it's a lot quicker. It's instantaneous.
That's excellent way or quality improvement, right? This is a practice that's implemented in many different pathways, of course, in the hospital, but particularly to ultrasound. to make sure that the quality continues to improve. These are residents in training, so junior residents obviously are learning, and more senior will be typically much better. But John, you're providing that oversight, right? And that feedback that you're talking about. So how it sounds like QA is a big part of your daily work or the work of the ultrasound division.
Yeah, it definitely, the way a residency is structured is that part of your documentation, when a resident sees a patient, they always have to have an attending physician. The attending physician at some point attests to being present for the key components of that exam. And that includes all procedures. So if they are doing an ultrasound on a patient, the attending has to be present for the key component of that ultrasound, and they have to review it before that chart is seen to be complete. And then a QA person, which is like a secondary way of reviewing that chart, then we are in the background, we're reviewing, did the attending pick up on all the findings, or was there something that could have been missed by both of them, or was there just more commonly, could they have adjusted their technique a little bit so that they both would have had a better picture, a better scan for the patient?
Got it. And I think also for the viewers, it's important to understand, of course, all hospitals have PACS systems, right? But PACS systems are just archiving. And this sort of intricate level of feedback is so important for physicians to get better. And you're talking about these disparate systems where you go from one system then to an email system and trying to provide more real-time feedback. It sounds just too clunky really causes a lot of barriers for the adoption of point-of-care ultrasound.
Yeah, definitely. It has to flow. Everybody's life is too busy, and so when there's barriers to providing timely, accurate feedback, the process tends to get bogged down, and it's not as beneficial to either the learners or to the reviewers in getting that information out so effective changes can be made. Right.
The other thing, with along the QA, QI avenue, which is a pretty big value proposition for Synchronicity, you're also a trauma center. And of course, the American College of Surgeons accredits a lot of trauma centers, and those that are accredited by the ACS, which is a lot, there's actually an obligation to maintain your trauma center verification status, which obviously the hospital has a big interest in doing. You have to do QA on trauma cases and trauma ultrasound. So that's just a reminder for the teams that are listening here that I'm sure there are many trauma centers in your regions that have this obligation, may not have sorted this out completely.
Yeah, there's no doubt, and it's part of a trauma evaluation. There's obviously friendly debate, but part of the initial evaluation of most critically injured trauma patients is a EFAST type of ultrasound. And we are, the emergency medicine physicians are very facile with it, but to get to the surgeons, we found that one of the barriers that before we implemented Synchronicity was that the surgeon would say, we know how to use your machine, but we don't know how to store the images, we don't know how to put them in packs, we don't know how they can be QA'd. And so what would happen is that they just would not pick up the probe, which was obviously impacted their learning. So now we've found that the way Synchronicity works, it's a lot more user-friendly. So even without the benefit of the onboarding that most sites require, you can do just-in-time teaching. And so we had some really interesting cases where a surgical resident, we had some one-on-one time, and then literally the case that comes to mind, we had he came down for a trauma. It was a stable patient. I walked him through how to do the exam and how, more importantly, he knew how to do the exam, how to store the exam on Synchronicity so that it could be reviewed, QA'd, and then put into the permanent system that you referred to, and also into the EMR. Literally 2 hours later, we had another moderate trauma, and he said, let me see if I remember, and let me try to do the exam. And he was able to input it all and actually made a really nice diagnosis. And that was a really neat for a residency program that doesn't use this every day to be able to pick up that quickly. So it just shows that it's a lower barrier. That never would have happened with our old system. It is just too difficult to navigate. So I really like that aspect of synchronicity.
So it sounds like the user interface, the usability of that is incredibly important. And that was a pretty concrete case you described, where, you know, it's very typical, and people should know that you will have physicians from other departments that are going to be involved in patient care, and trauma care is a very good example. And so for another department to immediately be able to input into synchronicity versus having to, you know, do a lot of online training or courses, that's a huge advantage.
Yeah, as we all know, trying to get folks to do a lot of preparation is very challenging. And so and even if they don't pick up the probe for a while or use the system, on other systems less intuitive, it can be really hard to get those pathways developed. But I just thought it was really nice to see a system learn so readily and then be available the way it's supposed to be. So it's very helpful.
Okay. So I want to switch just a little bit to credentialing, and just to remind the viewers, right? So we have physicians that do training exam on X number of training exams. They are credentialed for that procedure. And in this scenario, we're talking point of care ultrasound. It could be a different exam. Tell me how your credentialing worked with workflow prior and now, and your experience with synchronicity.
Sure. The way credentialing, there's you can look at it at two different levels. There's attending physicians, which I think is what you're driving at. So those are folks that have graduated already, and when they start at an institution, they need to come. Every hospital has a different criteria, but in general, if you graduate from a program that did ultrasound, you basically have that privilege when you start. But every 2 years, you have to be able to demonstrate that you retained your skill set and whatever privileges, whether it's other chest tube or ultrasound. And while each hospital is a little bit different, it's not uncommon for them to want to have your ability to show you've done a certain amount of study in different areas. There are some areas or advanced applications where most institutions will insist on those kind of numbers. It was very, very difficult to pull up those numbers in the past using our prior system. But now you can do that really contemporaneously. Once you learn the system, which is not that difficult, you can generate an administrative report. You can look up by the name of the provider and in a specific date range, which is typically 2 years before they're sitting for recredentialing, and by exam. And that way, the person that's responsible to help that physician recredential has all the data that they need when it comes to point of care ultrasound.
Okay, so sounds like it's now worked out well, which is great. So we talked about QA, which is really important. We talked about credentialing. So let's just switch to billing. You did mention a little bit about documentation, that the attending needs to sign off and all this. So tell us pre-synchronicity, the billing of your point of care, how that worked, what worked, what didn't work.
Yeah, so we've always billed for our ultrasounds, which is, for some sites it's an anomaly, but I think it's very important. I think part of it is the barrier to documenting what's required before you can bill. It's a certain amount of elements, and there's a number of key points that have to be addressed in a report before an ultrasound can be submitted to Medicare or a commercially indemnified payer to be eligible to be paid. One of it is storing in the long-term system, like you mentioned, the PACS system. So it has to be storable. The other is just hitting those data points. why was the study done, what was seen on the study, and what's your interpretation of the study, and then that you sign that you've done it yourself and you've interpreted. So there's some key points that are beyond somebody's ability to memorize it and just write it down. So what we had before was a system that was, as I mentioned, very difficult to use, and when it worked well, it still resulted in a number of charts being incomplete because it was still difficult to use, even when it worked well. And when it didn't work, when it especially didn't work, if it has a chart is closed, so several days, typically several days after somebody gets seen, the chart needs to be closed and the whole billing process needs to be submitted. If the documentation for the ultrasound hasn't happened at the time of the visit, which is not uncommon when it's really busy and when you have a training program or when there's other real life barriers that exist, now the challenge is to complete the reading of the ultrasound and then put it into what we call an archive chart. That was almost impossible in the old system. And so now using synchronicity, what's nice is that we're able to capture the essential elements of the coding for a number of reasons. One, it's laid out in a lot clearer fashion. Another big assist is that you can use the worksheet, which is built into the Sonosite units at the bedside, complete the reading there, and then that gets pulled into the packs, and then that can get pulled into your EMR. So moving from our old system to our new system, it eliminated a lot of the potential breaks in the chain, and all it takes is one, and then that study doesn't get read. So I would guess, and I don't have exact numbers, and it's hard to be specific, but I would say easily that we weren't capturing 40% of our pre-synchronicity charges. And we've at least decreased that by a factor of 50%, if not more. Again, it's hard to get exact numbers, but I'd say that we're close to the 80 to 90% capture rate. And I know that number is going to go higher just because, remember, we're still a beta site. We're still only 4 or 5 months into it. We're making a lot of adjustments back and forth as we figure out the workflow. But I think that those numbers will just continue to improve.
So that's a substantial improvement in compliance, right? And you really, I think, depicted well the pace of the documentation that's required, right? And it sounds like the onboard documentation, real time at the point of care, help this revenue cycle management, right? So that the chart could be closed and completed, versus sounds like about 50% of the cases weren't being even billed, though the work was done, right? And it was not billed. So that's lost revenue for those groups.
Yeah, there's no doubt that we've really ratcheted up the charts that are fully coded and therefore eligible to be submitted for bills. And not only, I think part of what's the attractiveness is we're just a part of it, right? That's just our professional fees. And then of course the hospital, as you know, has the facility fees, which are, depending, I've never been able to find a great number, but it's definitely a multiple of at least 3 up to, I don't know, 7. So there's what we are able to generate in terms of revenues for the group is multiplied by the hospital, and therefore makes it that much more, you can show that to your client hospitals. It really makes it just hard to pass up that potential increase in revenue.
And I think that's a really good point, John. So the professional fee and the technical fee. In the beginning of this interview, we talked about how ER volumes have dropped really across the country. A significant amount, right now about 80% pre-pandemic across the board. So ER groups are hurting right now, and they're not staffing up, et cetera. So this is revenue that's sitting on the table, right? Both for the hospital, which is also in a difficult situation revenue-wise. And so the value, sounds from what you're describing, a really strong value proposition, right? You have a critical that needs to be done for many emergency conditions, and in certain circumstances, mandatory, right? And we have VR groups in the country that are, because of the workflow, the clumsiness, just have not even adopted or are missing money because of this lack of seamless documentation.
Yeah, there's no doubt in my mind. If we're any kind of an example, folks are trying their best to keep up, and it can be difficult to do so. But if you give them the right tools, that allows them to chart contemporaneously, because that's really where, if you can do it at the point of, you can do, it certainly benefits your client hospital as well too.
Yeah, and the term that goes around a lot is phantom scan as well. These scans that are occurring, but never really documented because people are in a rush, right? So they sort of do it. It is used in clinical decision making, but when it's not really documented, it's not good, right? It's not good because the care is not documented, and it's also not good because there's loss of that revenue capture. So any idea what your phantom scans were like prior versus now? Any sort of gestalt on that?
It's hard, as you can imagine, trying to what is it? You can't measure a negative, but certainly anecdotally, there was a number of scans that were done that help drive a decision, help manage a patient, but simply weren't stored correctly or weren't even stored in the first place. What I like, I was never a barcode believer because I've seen some of the misadventures with nursing in terms of supplies and just our own internal systems. But we use the barcode scanner, and it's been really seamless. Once it's set up, it's really seamless. So what's nice as a provider, I can go into a patient that just arrived, whether they're an unstable trauma or unstable medical patient that hasn't had time to be re-registered. I just scan my badge, so now I know I'm attached to this patient. By the time I'm done with my exam, and I'm sure we're in the middle of how quick a registration process is, but really by the time I'm done with the exam, the patient has got an ID on. I just scan their Q code, and now all of a sudden I've got their name on, with my name on the right exam, and then I just read it at the bedside and I send it and I'm done. So it really, there is no reason to have phantom scans now. It's a matter of a second scan and a 1 second scan of your badge and a 1 second scan of the Q code for a patient that's not even that you haven't formally put an order in. So it really eliminates a lot of barriers. So I think the percentage of phantom scans now is close to zero. Certainly when I'm around, it's zero because the residents know. But beforehand, I think that it was significantly higher. I honestly can't give an exact number, but knowing how high our volume was before and how frequently we used ultrasounds before, but seeing what finally made it to a codable, billable number, the percentage had to be 25%, I'd guess.
It sounds from your description that barcodes are critical, right? We just implemented them at USC, and I see the same immediate benefit. It's probably worth reminding the viewers what unfortunately most ERs are doing. Most ERs are not billing right now, and it's certainly not the community one. So there's a lot of areas to improve. The other thing is, many of them are still manually inputting, finger type by finger type. They're using flash drives that are then going to an Excel spreadsheet. It's a complete disaster, really. And so you think about all the pain points, right? This is about solving the problems. And, what we're always trying to do at Sonosite, ease of use is sort of like one of our pillars. And it sounds like synchronicity has made life much simpler and better for you and the program to get all together.
Yeah, there's no doubt in my mind, just having been here before and after, and having been really in a role where I could see the evolution of ultrasound at our site. There's no comparison. I mean, I would have to manually pull out charts to see what was missing for QA, what was missing for coding. I was always emailing our physicians, and then trying to email the residents that were supposed to do it first, and then email the physicians that were supposed to sign. It was a horrific process. And now there's a lot less cases when that happens. It's a lot easier to fix when something falls off, because typically there's at least one identifier that we can latch onto and then reach out and have people do the correction. But really, it's just the fact that like you said, you've eliminated the pain points, especially up front. The key is getting people to do the work right up front, and then everything else falls into place. And with the barcode, with the worksheet, with the integration between our exports and synchronicity, it really it takes those pain points away.
So that actually leads me to my next question about doing onboard documentation, right? So tell us a little bit about, obviously you have exports with embedded worksheets. I see it sort of as chocolate plus peanut butter, putting those together. Good things happen when in that combination, basically. Tell me, like, how important embedded worksheets are, whether it's export or even our new PX system.
Yeah, it's it makes it a lot easier if we're now focusing a little bit on onboarding. So as a residency site, we have new learners every 4 weeks at least. And it's not uncommon for us to also get new learners from other programs, maybe medical students, and then soon our APCs. So you have to have a system that allows somebody to rapidly learn it, to implement it, so that it doesn't impede in their use of the machine, because you have to learn how to do ultrasounds. So that's a challenge in itself for the new learners. But you don't want a second barrier there where now I've kind of learned how to do a study. Okay, now I have to record it somewhere. If you don't have an easy process to do it, that's just a tremendous challenge for new learners. So from day one, I mean, the orientation is how to do a scan, but the orientation also is how do you put it into synchronicity. And we were functional from day one, and I'm sure we'll talk more later about our installation. But really, every month when we have new learners, by the end of day one, if not sooner, they know the rudiments of entering of doing the exam, and then entering the exam, so they can be reviewed and QA'd and all the other steps. So it's a very new user-friendly type of system.
That's excellent. That's excellent. So actually, so you hinted on the installation. So, typically, these are pretty big projects. Hospitals are busy. They have a big IT department. You mentioned EHR. Tell us your experience of the installation of synchronicity at Kauai Delta.
Sure. So it was really, I've gone through a couple of major installations over the years. Most notably, we changed over to Cerner a little while ago. And so we all know that installations can be painful, and it really relies a lot on the support that you get. This was interesting because it was all remote. With COVID, there was no on-site assistance. So we had a long preparation, an appropriately long preparation phase where representatives from Sonosite worked with our IT department, and then I was invited at any of the meetings. However, I really try to limit myself to the non-technical ones, given my background. And so it progressed to the point where we were doing some trial runs that went smoothly. And then we came up, basically we evolved to our go live date, which was May 24th. We had basically turned off the old system at midnight, or I think 6 a.m. And we turned on the new system at 6 a.m. And we identified a couple of go live challenges, but they were readily they were easily resolved. We had some workarounds and then some long-term fixes, but we were live from day one, and we were using it appropriately from day one. We had remote at the elbow support. I couldn't ask for more responsive support from a firm. So very happy with that. And we had just great communications with them. As you can imagine, since we were the first site, while we had a lot of preparation, there were still a number of things that needed to be addressed. Just as you go live, that's going to happen. So throughout the entire process, we've been able to work together to make suggestions. You know, how do we tweak this worksheet? How do we change this process? Okay, these studies fell off the screen. What happened? Okay, this is what happened. And they got booted up again. So we've had a very, I think, a relatively very smooth and effective process from scratch to where we're at now. We still enjoy very good support. There's, you know, obviously I'd be lying if I said we didn't run into any bumps, but none of them have been major potholes which completely derailed the system. So it's been a really great relationship with the technical support from Synchronicity, and we continue to enjoy that to this day.
Well, thank you, John. We certainly appreciate that. I mean, Sonosite prides itself on customer support, and we want to make sure that this product is supported as well as every one of our products. I'm just curious, I mean, obviously I read the ASAP e-list, and some of the major concerns of program directors is the spotty support of certain companies that are in workflow. So what was your experience like, curious, prior to Synchronicity with your previous workflow?
I was told not to bash competitors, so I'm going to pick my words carefully. So the impression I got from our last company is that it was 3 people out of a garage. And it really, it was under the former director, and then I took over the reins, and we just felt our questions frequently went unanswered. And even as it came to the time we're looking at the product was going to be sunsetted, and they were migrating to a new platform, we just couldn't get any good answers, and certainly no timely answers. When I reach out to tech support, you know, I try to use the cell phone judiciously, but calls and texts are answered appropriately, and emails on less emergent issues. So our support before was limited to unresponded emails. The support right now is a very good response on texts, on phone calls, and on emails, which is the preferred method if it's not an emergency. So I couldn't, it's night and day.
That's phenomenal. I mean, as you know, our parent company, FUJIFILM, does a lot in IT. And so that background experience is, will translate to hospitals that are looking for a reliable partner, right? Now you mentioned tiny startup-like company versus if you're investing in an infrastructure like this is a big deal for not only your department, for the entire institution. So it sounds like, you know, you're about 4 months in or so. Has Synchronicity at this stage, the stage of sort of installation and experience, has it met your needs?
Oh, definitely. What we needed was a reliable system that was user-friendly, that had a very quick learning curve, that's customizable because of our multiple different learners, whether they're residents, whether they're advanced practice clinicians, whether they're medical students. It had to allow us to have a robust QA program, again, for the learners in our program. We are, again, a combination community academic site, and we rely on every nickel we can squeeze out of the insurance companies. And so our coding and billing processes had to be airtight, and they were. And then we thought, as I think most people think, that they should have a high degree of customer service when you're making an investment in a modality that you use every time you work a shift. and we have that met and exceeded as well too. So it's been, I think on every front that I've looked at, it's been a great partnership.
Well, that's fantastic to hear, John. This is really exciting for us at Sonosite. You're the first site that's
In the world.
fully in the world. We planted a flag right at Coya Delta. We're very proud of that. It sounds like your experience has been solid. The problems have been solved. We look forward to getting a lot more feedback. We're excited because we believe that workflow must be solved for point of care to grow. Given the expansion of point of care, the maturity of point of care, all of those things. So it's been really great chatting with you. We'll probably chat with you again for sure as time progresses. I know we have some of our strategic account team on, and so I do want to make sure they get a chance to ask some questions. They are obviously trying to get implementations and trying to meet with customers, see what their pain points are. So I think talking to you and hearing your own experiences has been good. But I want to open it up to them. There's a chat box there. I want to make sure they have a chance to ask questions directly to you. So I'll just give it a moment there. And I'm sure, Laura, if anything has come through.
Nothing yet, Diku. I'm just checking it out now, but so far no questions.
So, John, it was pretty impressive that all this happened under COVID, right? So
Yeah.
Not only were you the first installation, you managed to do it under COVID, which is remarkable in itself.
Yeah, it was certainly not the timing that any of us would have picked, and nonetheless, it did work out well. I think it's just a testament to dedicated teams on both sides, and just kind of sticking with the process. Obviously, we all wanted it to happen within a 3-day period. It took a little bit longer than that, but I think it was a realistic installation based on the unexpected catastrophe that we all face nowadays.
No, absolutely. Let's see, Laura, anything come through?
No, Diku, no questions.
Okay, no problem. So, well, John, on behalf of myself, the entire Sonosite team, thank you for spending the time with us today. Please keep us posted. Anything you need at Coya Delta, please let us know.
My pleasure, Diku. I'm looking forward to continuing to help refine the product. It just makes it better for us, and then it also helps everyone else that's interested in it. I think where we're at now with a community and academic hybrid really can appeal to a lot of folks, and that's how we'll continue to move forward, is try to make it as useful and as user-friendly as possible.
Fantastic.
We did just have a question come in. Do you guys have one more moment?
Sure.
So from your perspective, how do you see the Ultramobile handhelds fitting into your workflow? That's question number one. And then secondarily, does their imaging hold up to the QA?
Yeah, no, that's a good question. I hate to mention competitors. I don't think Sonosite's got a handheld, but we did test drive with Sonosite's help the most popular handheld that's out there nowadays, and the images went across just fine. We're actually in the middle. Anybody that works in a hospital knows how difficult it is for a new process. But we have 3 of those aforementioned units, and we are just at the last stages of implementing them into our workflow. We just need to find a secure form of swiping in and swiping out to use the units, because they are hospital owned. So the proof of concept worked because we could see the images on synchronicity. We'll just have to, I'm sure as we go through that workflow, that will identify a lot of challenges, but I don't anticipate them being insurmountable, and it really will add another dimension. But yeah, you're right. It has to be if you're talking about QA in regards to the handheld, it's going to meet the same standards. There's no difference from third-party payers or Medicare's perspective how you got the images. You just have to have the same elements, the same quality. And so I don't really foresee any problems with that either.
Great, thank you for answering that. And another question just popped in as well. Can you share a specific justification you utilized to gain capital approval with hospital leadership?
Yeah, no, that's a good question. So we had, like I said, a product that was going to be sunsetted. So it may be difficult. Well, it will be. It's easier if you're replacing a system that's going out of existence, because then you have to look at, do you invest in its replacement, or do you look at the competition and see what's out there? So when we looked at the capabilities of Sonosite versus upgrading or replacing with another system, the upfront investment was clearly worth it, not only to myself as a selfish end user, but to the hospital administration. I think but for most sites, it's what's the bottom line. So how can you show that it's going to be better for the patient? Okay, that's just ultrasound. But in terms of why use Sonosite, the middleware, versus some of those other competitors, I think the key point to emphasize is that there is less revenue stream leakage because of the fact that you're able to do everything at the bedside. I know I don't have a non-Sonosite unit, but I understand Synchronicity is agnostic. So I think if you can demonstrate the same workflow, if a site's already married to a competitor of yours, that's going to be the key, because again, doing the barcode scanning at the bedside, being able to read at the bedside, or if not, then immediately, because it immediately goes right into Synchronicity at the desktop. So if the system doesn't allow for a worksheet, it's right in the desktop. So I think that's how you demonstrate the value, is by showing that there's less leakage. So if you could find out how many of the scans are being done right now, not being coded and billed for, and then say at the one client site that we have, the percentage is 80% and going up, I think you're on pretty good ground to show that you're going to make the hospital financial return on any investment in the system.
Right, that makes sense, definitely. Thank you.
Sure.
Well, good. I don't see any others coming up here. So, John, thanks for spending the time with us, and we'll certainly be in touch.
Diku, my pleasure, and pleasure to everybody else.
All right, thank you.
Okay.
Bye-bye.